contrast to obstructive lung diseases, restrictive lung diseases are characterized by difficulty getting air in. They can be separated into two major categories, those of mechanical issues and those of interstitial issues, mostly fibrosis of the lungs. So again, mechanical, so this is hypoventilation, whether respiratory rate or tidal volume, and then interstitial, which is usually a fibrotic diffusion limitation. So with the mechanical, we can really further separate these into two more categories, those of muscular issues, so polio, ALS, myasthenia gravis, Lambert-Eaton myasthenia syndrome, Guillain-Barré, and then for structural, scoliosis, ankylosing spondylitis, and obesity, you should have a normal AA gradient. So chest expansion is limited. I mean, it's like imagine trying to take a breath with someone sitting in your chest. So again, whether it's either of these categories, this will lower your alveolar oxygen values and induce hypoxemia. We can also, we're kind of sliding this in, nocturnal mechanical hypoventilation. In other words, sleep apnea. So hypoventilation that occurs really just during sleep. So it's defined as a cessation of breathing for more than 10 seconds during sleep, a couple episodes a night. Obviously, somebody will be really tired. Nocturia, so going to the bathroom a lot, peeing when you're more than 2 episodes per night. Pulmonary hypertension due to the hypoxic vasoconstriction, but 2, the hypoxemia is going to induce hypoxia of the art. So coronary oxygenation is going to be limited, alterations to blood pressure. So tons of heart issues are associated with sleep apnea. 25% of men is very common in larger obese males. So notice here we have breathing, 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 flat, breathing, breathing, breathing. So this again has to be 10 seconds. Same thing here. This is really just obstructive versus central, which we'll talk about now. So obstructive is where you have literal tissue obstruction of the flow through the pharynx. So it's usually weight related. And then central, which is a little bit less common, is that the nervous system, usually due to some sort of maybe a stroke or opioids, is inappropriately monitoring ventilation rate in response to CO2 changes. So the central chemoreceptors are defective for whatever reason. So now getting into both of these categories. So everyone during sleep, I guess now we're just talking about obstructive. Everyone during sleep is a combination of gravity and your muscles relax when you're sleeping because of hormonal changes. This allows the tongue, so normally air goes like this, but these changes cause the tongue and everything to, the muscles relax, and then the tongue gravity pushes this downwards. So it's a little bit more difficult for air to get in. That is just regardless of whether you're the healthiest person on earth or not. Now this can be exacerbated, this problem of air getting in, through one, allergies. So if allergies get in, they can inflame the airway, making it more difficult for air to flow through. Infection, so swelling of the adenoid or the tonsillar tissues. I had a girlfriend who's normal weight, very healthy, and she had swollen tonsils, and it was causing severe sleep apnea. She had her tonsils removed, and it 100% fixed the issue. Some people have an overbite. The overbite, so pushing of the jaw back, will actually cause it more difficult for air to get in. And then lastly is if you're obese, you have this larger neck, extra soft tissue, obesity related, makes it more difficult for air to flow in back there. The main one, though, being overweight. So obese males over 40 is going to be key for sleep apnea. Now, essential sleep apnea, CNS injury, opioids, also congestive heart failure, interestingly, can cause this. The brain can't properly calibrate CO2 levels, so it's constantly overcorrecting. So for whatever reason, your CO2 levels are normal. Maybe they get a little bit high, and if they get a little bit high, the chemoreceptors in your brain go, oh, CO2 is too high. Let's start hyperventilating. It hyperventilates, which is going to blow off all of your CO2. It blows off too much. Now that it's too low, your brain wants to correct in the other direction. So no apnea, a cessation of breathing or hypoventilation is going to now correct for this, and the CO2 levels are going to rise. Now let's just focus. From here to here, we're looking at this hyperventilation, right? Hyperventilation. And now from here to there, this apnea is, well, that's where the sleep apnea comes in. So again, this has to be 10 seconds. And now this pattern of hyperventilation with apnea, hyperventilation apnea, is known as Cheyne-Stokes respiration. And the difference really between obstructive and central sleep apnea can somewhat be illustrated here. Notice, again, we have the 10 seconds no breathing, 10 seconds no breathing, but in this case here, there's no effort put in. I'm not seeing the chest and abdomen really move up and down. Here it is moving up and down, but it's just no air is getting through. So which one's which? This is going to be central sleep apnea, and this is going to be obstructive sleep apnea. Treatments, avoid depressants. So remember that gravity closes, access from your pharynx into your larynx, but also the muscles relax as well due to hormonal changes. Well, depressants are just going to further relax the throat muscles, make it collapse even more. It's even more difficult for air to get in. Sleeping on the side is going to allow better airway into the lungs. CPAP, continuous positive airway pressure, forces the airway open. And the problem here is that there's poor patient compliance. I think the mask is just kind of, I have a hard enough time wearing my mouth guard. I can't imagine wearing this every night. So poor patient compliance. Surgery, like my lady friend, to remove tonsils, adenoids, reline the jawbone if you have a overbite. And then oral mouthpieces as well can go ahead and move the jaw forward, which moves the tongue and a lot of these muscles forwards and this tissue forward so that the air can get in a little bit better. All right, so interstitial lung diseases. So this is just general hypoventilation. Or I should not actually know, getting outside of hypoventilation. This is just interstitial lung disease. So this is usually going to cause fibrosis, which limits diffusion. Usually microparticles get into your alveoli. Sometimes you have idiopathic pulmonary fibrosis, which is just for whatever reason you get old and things get fibrotic and crappy. But other than that, we have microparticles that can get in. And maybe this actually contributes to idiopathic, and it's just harder to point the finger at somebody. But macrophages, neutrophils will come up, release chemokines, more immune cells are going to come in. All of this stuff, as always, it damages the epithelium. Fibroblasts are going to come in and lay down extracellular matrix. Again, we have several different types: idiopathic, sarcoidosis, drug toxicity, bleomycin and busulfan, the chemotherapy drugs, hypersensitivity, pneumonitis, birds, pneumoconiosis, asbestos, berylliosis, silicosis, and coal-induced pneumoconiosis, which is really just the same name. So healthy alveoli diffusion is no problem. Fibrotic alveoli, again, in response to any of these things, it's just the distance is a little bit too large. And if we remember from our formula, that makes it difficult for gas to get through. So CO2 is 25 times more soluble, which means that because it's more soluble, diffusion is easier, but oxygen is a little bit more of an issue. So this is normal. This is going to be perfusion limited, but you know what? Now we have diffusion limited, especially if exercise is present. So with most of these interstitial lung diseases, you get reticular opacities. Reticular just means net-like. Sometimes these are also called honeycombing, and opaque really just means you can't see through it. So you can really kind of see the honeycombing, which is really just another name for the reticular opacities here. But you can kind of see it here as well. So really important just to be able to eyeball this on a chest x-ray or an axial MRI. Sarcoidosis, which is really the first of these, sarcoid flesh osis disorder, flesh disorder. Just remember that you're going to have these papules on the back. A lot of people get erythema nodosum, so there's a lot of skin flesh related symptoms here. And in general, sarcoidosis is a system-wide disorder. However, it does have an emphasis on the lungs, especially we're going to have the hilar lymph nodes involved. So the dendritic cells get activated. Triggers not well understood by some pathogen. They migrate to the lymph nodes. They activate the immune system. Causes lots of symptoms: Bell's palsy, where the facial nerve is damaged. We get a drooping of the face. Inflammation of the eye, and erythema nodosum, which we've talked about. Sarcoidosis findings. So often this affects young Black women disproportionately. So look for that in the vignette. Granulomas, specifically non-caseating granulomas. So granulomas are usually caseating or non-casing, which really just means necrotic or non-necrotic. So it's not a necrotic core. A necrotic core would be something like tuberculosis. This is really where we have like a cluster of lymphocytes surrounding epithelial cells and multinucleated giant cells, which are really just lymphocytes which have merged with macrophages and epithelial cells. And we have these, again, you have this honeycombing, this reticular opacities. What you can kind of see here, there's a little bit involvement of the hyaloid lymph nodes. You can see it a little bit more in this CT scan. And the reticular opacities, again, are really clear when you look at the axial MRIs. Paraneoplastic syndrome, so macrophages, which are present in the granulomas, possess 1-alpha hydroxylase. These are necessary to activate vitamin D. So here's the pathway. So they don't really create vitamin D, but they help create the activated functional form of it. This is going to increase your calcium levels. Also, ACE is going to be present. Interestingly, I don't think that this actually is really strongly associated with an increase in blood pressure. Maybe it's because we already have enough ACE, and that's not the rate-limiting component. But nevertheless, an increase in ACE is also symptomatic. Birds, that's really all I would know. You see hypersensitivity, pneumonitis, and birds, those go together. So pneumoconiosis, there's a couple different types. Types that affect the upper lobes and type that affects the lower lobe. So really this is breath dust. So any sort of dust that gets into the lungs can be considered a pneumoconiosis. Coal workers pneumoconiosis, so coal gets in, also known as the black lung. Silica, so people working in the silica mines, I think this is prevalent in areas in India. People do sandblasting here in the States, kind of like a pressure washing, but with sand, so it's even better at getting off rust and, stuff. By the way, interstitial really just means between things. So interstitial comes up a lot. So interstitial just means between sand particles, and here we mean between lung tissue. So it's not in the alveoli, it's in between the alveoli. Sorry, that's a side note. Back to this. So for the lower lobes, we have asbestos. Asbestos, we see this in roofing and insulation and plumbing, people who work in construction or shipyards, old houses especially. And so there's a lot of lawsuits for mesothelioma that I'm sure people, there's tons of jokes about them. You see them, all over the TV and the internet. And the question is, it's kind of interesting because asbestos is actually more associated with bronchogenic carcinoma than it increases the risk of mesothelioma. So what's going on? Well, first, bronchogenic carcinoma really just means any old lung cancer. It's just sort of an outdated term. So just lung cancer. So why aren't we getting lawsuits for lung cancer if it's more commonly linked to asbestos? Well, the reason is that many things cause lung cancer. So if someone gets lung cancer, it's hard to point the finger specifically at asbestos. However, pretty much only mesothelioma is associated with, or mesothelioma is really only caused by asbestos. So if you got mesothelioma, it was probably from asbestos. So it's easier to pinpoint the finger at some organization you used to work for and initiate a lawsuit. There's about a 50-year latency for asbestos exposure. So if someone had exposure in the 70s, well, they're going to be getting mesothelioma about now. So even though they discovered the health risks and started getting rid of asbestos from housing insulation and whatnot in the 70s and 80s, well, again, it still takes 50 years for the cancer to kick in. So even though we stopped here, we're seeing the numbers rise. Eventually, they'll start to fall, but that would explain it, this time lag. Things to look out for: pleural plaques. You can see them here. You can especially see them on the axial MRI. You can see them here a little bit. And ferruginous bodies are dumbbell-shaped particles ingested by macrophages.